Here we describe a neglected case of primary bladder neck obstruction who presented with obstructive uropathy with renal failure. Urinary trouble in young males is not just because of UTI or urethral stricture. There are multiple other reasons for these troublesome symptoms. Primary bladder neck obstruction in young males is often an undiagnosed entity. Delay in the treatment can lead to obstructive uropathy with renal failure. Here we describe a case who was 30 years male. He presented with difficulty in voiding, was treated by GP for UTI, and his serum creatinine reached to the value of 3.4. He was referred to us. On ultrasound, the residual urine was 250 ml with bilateral hydrouretronephrosis. The uroflowmetry showed an obstructed flow pattern with a maximum flow rate of 9 ml per second. The urodynamics was performed, which showed a maximum detrusor pressure of 62 with a Q max of 7 ml per second. A micturating cystourethrogram was performed in which multiple outpouchings could be seen in the bladder outline, suggestive of multiple saculations and diverticuli as a result of bladder neck obstruction. And in the voiding phase, one can appreciate partial opening of the bladder neck or a non-relaxing bladder neck. So the patient underwent transurethral bladder neck incision. This is the sphincter, the virumontanum, an elevated bladder neck. Turbid material present inside the bladder. Gross back pressure changes in the form of multiple trabeculations and saculations. In the initial cystoscopy, the patient had good efflux from the right ureteric orifice, whereas the left UO was having pinching effect, so a left side DJ stenting was done. So this is the bladder neck incision on the left side. In the bladder neck incision, the key points to remember is that the proximal limit of incision is till the level of ureteric orifice, and the distal limit goes up to the level of virumontanum. We have to spare the sphincter, we have to spare the anterior commissure, and the incision is made deep enough up to the level of capsule. A similar incision is being given on the right side. The virumontanum has to be spared and the incision extends up to the lateral margin of the virumontanum. Following the incisions, proper hemostasis is secured and a wide bladder neck can now be appreciated. That's the right ureteric orifice. That's the virumontanum. The patient was kept on a urethral catheter for 4 days. So that's the uroflowmetry after the procedure of transurethral bladder neck incision with a very good flow rate reaching up to the level of 30 ml per second, and the patient's serum creatinine is gradually decreasing and has come down to the level of 2.5 mg per deciliter. So primary bladder neck obstruction in young males has to be recognized early, otherwise it can have catastrophic effects on the patient's kidney and patient's survival. Thank you.